Dear colleagues and friends, Yassas, this would have been my first visit to Greece, a lifelong dream, and my first opportunity to spend some quality time with the IFFS community. So please accept my sincere apologies for not being there in person. I'm therefore really grateful to Dr. Edgar Mocano and the IFFS Executive Committee for allowing me to share a few thoughts with you via video. I have a view of a park from my window, and it's an absolute delight listening to the children squealing with laughter as they chase each other around and play. It's reminiscent of a time of innocence, free of the obligations and complexities of adulthood. And yet there is such a sense of urgency to grow up, to have greater control, and to be a part of a world with increasing complexity. To discover one's identity and fulfill the expected roles as parents and carers of the older and younger generations, as employees and part of a productive workforce, as decision makers with responsibilities not just for ourselves and our families, but also for the populations we serve as healthcare providers, demographers, policymakers, and educators. And to do this in a world that is fraught with global tensions, with inequalities, with climate disasters, with mass movements of people, and with shrinking fiscal spaces. And indeed, the one thing over which control has been guaranteed is one's body, the health and well-being of that body, how that body will be shared in the context of intimate relationships, and the ability of the body to procreate. So this brings me to one of the main focus areas of this conference. Dr. Gitao Mburu and colleagues from our team at the UN Special Program on Human Reproduction, HRP, and the WHO Department of Sexual and Reproductive Health and Research recently published the Global Infertility Prevalence Estimates. Infertility is a major and widespread health issue affecting millions of people around the world. 1 in every 6 people of reproductive age globally experience infertility in their lifetime. We still need to work on the trend data and how to accurately reflect the range of causes of infertility. We know, however, that infertility can have a negative impact on mental well-being, relationships, and quality of life, and is implicated in the occurrence of intimate partner violence. In addition, there are marked disparities in the availability, quality, and access to services for preventing, diagnosing, and treating infertility between regions, countries, and populations. Current evidence shows that only about half of all infertile couples seek any form of fertility care, which is partly due to geographic inaccessibility, financial burden, and social stigma. The financial costs of fertility care are often prohibitive. In the recent analysis, my WHO and HRP colleagues found that, on average, direct medical costs for assisted reproductive technologies in low and middle-income countries exceeds the per capita GDP, anything between $2,000 and $18,000. In the absence of policies that make fertility care available to all, the path to parenthood will remain inaccessible for many, especially the most marginalized. Universal health coverage is supposed to guarantee that all people have access to the health services they need, when and where they need them, without financial hardship. This includes the full range of essential services from prevention, diagnosis, and treatment. So to achieve universal health access to fertility care, 6 things must happen. And this is where we can provide some leverage. First, the prioritization of infertility in national health systems and financing. In many countries, infertility is not prioritized or included in health strategies, services, or benefit packages. In 2009, infertility was included in the International Classification of Diseases. The inclusion shifted the definition of infertility from a condition to a disease. This shift has facilitated the inclusion of infertility in national health policies and into insurance schemes. In the last few years, several countries in Africa and Asia have introduced infertility within national health sector strategies. However, much more needs to be done to ensure that it is fully addressed in those and in all other countries. More recently, the WHO has established a UHC, Universal Health Coverage Compendium of Interventions, which is a database of health services to assist countries in the compilation of essential services to be included in UHC packages. The compendium includes over 3,500 health actions across different health areas of clinical care. Included within these are infertility services to be included in packages of fertility care. We encourage member states to utilize the UHC compendium to identify interventions that can be implemented within available health financing resources. Second, cost reduction. It is essential to work together to find ways to make fertility care more affordable through innovative service delivery strategies, including through primary health care. Third, raising awareness about infertility and fertility care. Many social norms stigmatize infertility and affect reproductive decision-making. However, there is very little investment in education and mental health. Fourth, harmful gender norms and inequities disproportionately affect women who tend to be blamed and disproportionately bear the stigma of infertility regardless of the cause. At the same time, men who tend to have low engagement with services in general must be supported to access prevention, diagnosis, and treatment services. Fifth, there are gaps in our data, making it hard to get the whole picture. We need better data, and this includes assessing the need for fertility care outside of heteronormative couples to ensure that rights are protected for all, leaving no one behind. Finally, the widespread availability of effective national clinical guidance is also needed. WHO recently launched the 6th edition of the Semen Manual, with updated, standardized, evidence-based procedures and recommendations for investigating male fertility status, as well as monitoring spermatogenesis during and following male fertility regulation and other interventions. I'm pleased to note that it is widely used and is now available in several UN languages. However, many countries do not have national clinical guidelines related to infertility prevention, diagnosis, and treatment. While professional societies have filled this gap in some instances, the continued lack of national guidelines developed or endorsed by ministries of health hinders the consistent use of cost-effective interventions and increases the risk of unsafe interventions. WHO is currently developing infertility guidelines to also include how to apply a gender and human rights lens in fertility treatment. The WHO obviously cannot do any of this without the support and collaboration of the IFFS and its members in both the public and private sectors. We need to ensure that we have the high quality data to support monitoring and prioritization of this work. We look forward to working with the IFFS and its members in the coming years to ensure the inclusion of fertility care in universal health coverage in all countries. Thank you so much for your ongoing commitment to ensure access to safe and effective services for people experiencing infertility, and I wish you a very successful conference. Thank you.